Hi Miley, I'm going to be performing your abdominal exam today. Can you go ahead and pull your shirt up for me? Good. I'm going to be speaking again for the students so that they can hear me and know what I'm doing. Okay. I'm starting with inspection, just inspecting her abdomen for the shape, looking for any pulsations, any movements, pulsations from the aorta, the peristalsis, or the waves of the bowels, which a lot of times you can see. Then obviously you can see her breath as she breathes in and out. The next part of the abdominal assessment after observation is auscultation. So I'm going to grab my stethoscope. And I'm listening for bowel sounds in each quadrant. So we like to break up the abdomen into 4 quadrants. The right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. And you're listening for the tinkling and pingling, tinkering and pinging of bowel sounds. So it should be between 5 and 30 per minute. While I'm auscultating, I can listen over the spleen and over the liver for any splenic or liver hepatic friction rubs. So on the right hand side, the splenic rubs, we're going to use the bell and listen for any hepatic friction rubs. And then going to move over to the other side and listen for any splenic rubs. Good. Next I'm going to listen to the aorta, which branches down right above her umbilicus, with both the bell and the diaphragm. The aorta then splits off into the iliac arteries and the renal arteries. So iliac, and then branches down further to the femoral. So here I listen to the femoral artery here and femoral artery on this side, with again both the bell and the diaphragm. Listening for any vascular sounds like bruits, which are going to be turbulent sounds. The next part after auscultation is going to be palpation or percussion. We're going to start with percussion. Percussion is a technique that requires some skill and some practice, but generally you take your dominant finger, your right hand or your middle finger of your dominant hand, in this case it's my right hand, and you strike the distal joint of your non-dominant hand middle finger. And it's a quick strike, strike, and then lift up so that you don't dull the noise. So I'm going to lightly just percuss in all 4 quadrants of her belly, listening for the tympanic sound, which is that sound of a drum, because in her belly is a lot of air, and there shouldn't be fluid or any structures that cause it to be dull. I'm going to percuss for the liver border. So I'm going to start in the midclavicular line around the umbilicus and percuss upward until it changes from tympanic to a dull sound. Once you hear that dull sound, you can mark that level, and then again start superiorly, go between the rib margins, because the ribs, if you percuss the ribs, they're going to be dull sounding. So you want to percuss in between the ribs until you hear the dullness, and then you want to mark that liver border. It should be anywhere between 4 and 7 centimeters or so. You can do the same thing on the spleen side. It's harder to percuss the borders of the spleen because the spleen is located completely under the ribs and off to the side. So what you can do is around the 10th rib, sorry, my hands are really cold, Miley. Around the 10th intercostal space, so count the ribs. You know the bottom rib is the 12th rib. Count up 11, 10, 10th rib. In that 10th intercostal space in the anterior axillary line, so the anterior axillary line, you can percuss here. And you're percussing to see if that's dull. If it's dull, and then you can have the patient take a deep breath in and percuss again. Good, and now it's in panic. So that spleen is shifting up, so there's no splenic enlargement. The next part after you percuss the abdomen is to palpate the abdomen. I'm going to start with light palpation. Again, I'm using just the pads of my fingers and lightly palpating in the right upper quadrant and the left upper quadrant, and then the right lower quadrant and the left lower quadrant. The light palpation gets the patient used to your touch, gets any of the giggles out, gets the coldness of your hands, gets them familiar with that, and it allows their muscles to relax in their stomach so that you can then go ahead and do some deeper palpation. In the right upper quadrant, when you deep palpate, you're going to deeply palpate for any of the structures there, and the main structure that's here is the liver and the gallbladder right behind the liver. So you're going to press down and then press up towards the costal margins. You can see Miley's ribs clearly here, so you want to press down and then up underneath the ribs to try to feel the liver border. You can have the patient take a deep breath in, and that liver will sometimes come down and that border will hit the tip of your finger. You can then go to the left upper quadrant and do the same thing. Press down and try to go underneath the rib margins to see if you feel any spleen. A splenic border here is not a normal finding, so you shouldn't actually be able to palpate the spleen. If you can, that means the spleen is enlarged. Deep palpation again in the right lower quadrant. The main structure that's down here is appendix. There's also bowel. In the left lower quadrant, deep palpation, going to feel the colon. So a lot of times that can be tender. It shouldn't be real painful, but there is some tenderness associated with palpating that colon area. Other techniques with feeling the liver is called the hooking technique. It's hard for me to demonstrate in this position, so I'll show it to you on her left-hand side, which is obviously not where her liver is, but you take your fingers and you actually hook them underneath the costal margins, and you're hooking up this way. So you can actually see that's her rib right there, and I'm just hooking my fingers underneath her ribs, underneath the costal margins right here. And then I would have her take a deep breath and try to feel that liver border as it comes down and bumps against my fingers, which again, liver is not on the left side, it's on the right side, and you should all know that. While I'm pressing, another special test that you can do is called Murphy's sign. It's a test for cholecystitis. While you're deeply pressing down in the right upper quadrant and pressing for that liver, you can have the patient take a really deep breath, and if the pain is so severe that it causes them to cease their inspiration, so it's a cessation of inspiration due to pain, that means that there could be some inflammation in the gallbladder. So if the patient is unable to take a deep breath while you're palpating deeply in that right upper quadrant, that can indicate some cholecystitis or gallbladder inflammation. Moving down to her right lower quadrant, some of the special tests you can do is find the ASIS, or the anterior superior iliac spine, the hip bone on the anterior side, and then find her belly button, or her umbilicus. About 2/3 of the way down between the imaginary line between the ASIS and the umbilicus is what we call McBurney's point. That's the point where the gallbladder sits right below. So deep pressing in there can sometimes reveal pain, which may be associated to appendicitis if the patient has other clinical symptoms that indicate appendicitis. Other tests that you can do for appendicitis include Rebound Test. Rebound is when you press deeply into the stomach and then you suddenly let go, and you ask the patient which hurt more, and if the initial pressure hurt more, or if once you let go of your hands, if that rebound is what hurt more. A special test called Rovsing's is when you do a rebound test on this left side. So you press in on the left side and you let go suddenly. If that causes pain on the right side over that McBurney's point area, then it's indicative of a potential for appendicitis. The next test is called the Iliac sign. It's also a test for appendicitis or for peritoneal inflammation. I'm going to have you press your thigh against my hand. Good. Go ahead and flex your knee a little bit and press up against my hand. Good. If that caused pain in this area, again, you could also test the other side against. Go ahead and press up against my hand. Good. If that causes pain, then it's likely that the patient has some peritonitis or peritoneal inflammation. The next test is the Obturator sign. I'm going to have Miley flex her knee, and then I'm just going to internally rotate and externally rotate that knee. If that causes any discomfort or pain in that abdominal area of McBurney's point, then that can indicate appendicitis or peritonitis. There's one more series of special tests, and those special tests are to assess for ascites, which you can obviously see that Miley does not have any ascites. But if you did suspect a patient had ascites, you could percuss the border, so percuss around the abdomen. You would expect that the protuberant abdomen up here would be tympanic, because it would be all air-filled, because as the patient lays down, the fluid from the ascites would shift to each lower area. So then you would percuss the flank or the borders on each side, and that would be dull because that's where the fluid sits. You would then have the patient roll to one side. Good. And when a patient who has ascites, then the fluid that was here has now shifted and is all down on the dependent side, because fluid goes where it's dependent. So then you would then again percuss the flank here, and you would expect it to be tympanic because the fluid has now shifted. Good, relax. The last test for ascites is the fluid wave. If the patient had a round protuberant abdomen, I would take the patient's hand or a nurse's hand and press it in the midline of their abdomen right here. And this is just going to help keep other structures from going from one side to the other, not the fluid. With my hands, with my right hand, I'm going to sharply push on the fluid on one side and look to see if it causes a wave or a slap on the other side. So with one hand, I would push into our stomach and feel if the fluid then travels through the stomach over to the other side of my hand. And that's the fluid shift test, or the fluid wave test for ascites. That concludes our abdomen exam.